I hate to say it this way, more times than not, it's not the thyroid.
Yes.
When people come in. But definitely when the thyroid is off, it's really important that we get that treated. So here with Ricardo on Atlas Answers, and today we're going to be talking about a patient who, pretty common for us to see in the clinic. They'll come in mid-50s. They've read weight gain can be associated with a low thyroid and as well as fatigue, and so they want their thyroid checked. So if somebody comes in with that, what are some of the things that you're thinking when we see that person come in with the weight gain and fatigue, in particular, sort of looking at a thyroid aspect of it?
That is one of our common things that we do see a lot of, and initially we'll do some testing, thyroid testing, to bring in T4 counts, TSH counts, and sometimes you may have to go a little further and investigate that. But that's usually where we'll start in investigating that.
And so for those who don't know, when we look at those, particularly those two numbers, right, we're looking at the TSH, which is really this hormone, if you will, that the brain is secreting. Most people think of hormones, we think of estrogen and testosterone, but this is a hormone that the brain puts out when it says, you know what, I either have enough or I don't have enough. And so the TSH actually moves the opposite direction of what the thyroid is. And so if the thyroid level is low, then the TSH, which is the thyroid stimulating hormone, moves up.
Yes.
And then we use the T4, or really probably more specifically the free T4. And that's really what the thyroid itself is producing. Really sort of the main driver back towards the TSH, right? Yes. So that if that's low, the TSH goes up, and if that's high, the TSH goes down. What about when the person comes in and they say, I'm having some weight gain, I can't get this weight off? What percentage of people have low thyroid?
Well, rough estimate, about 15% of people may have some hypothyroidism, whether it was acquired through surgery or whether it's genetic. Okay, a genetic component of that. And basically that's sometimes the body will attack the thyroid, and over time, slowly people may start to feel this fatigue, you see the weight gain, these type of things. So about 15% is about an average.
Yeah, I hate to say it this way, more times than not, it's not the thyroid.
Yes.
When people come in. But definitely when the thyroid is off, it's really important that we get that treated, because when the thyroid is off, people just don't feel as well. But also, the mortality rate for people with hypothyroidism untreated gets higher, and so it's important to get that treated. What about for symptoms when people have the thyroid that are too high? Classically, we always think about that as being, we think about people with Graves' disease, right? We see their the eyes, right? That's kind of the med school answer, is you look at their eyes and you look for, if their eyes are bulging out, that's a sign of Graves' disease. But far more commonly, right, people come in, oddly enough, sometimes with a similar set of complaints as with low thyroid. And so that's, I think, sometimes a little bit hard for people to understand, is if their thyroid is too high, it can also cause a lot of the same symptoms.
Yes.
Even though classically that's not what we would see, right? If I look for the answers on the test, right, people feel like they're having weight loss and they're hot all the time, and they have a lot more energy, or they're more anxious, or their heart's racing, and all those things are definitely true.
Yeah.
But also, the symptoms of low thyroid and high thyroid have a lot of overlap with them. I think probably the most worrisome thing for me, particularly when somebody comes in with a high thyroid, is their heart rate. So many times I'll see the heart rate elevated, and just a mildly elevated heart rate may not be worrisome, except for the fact that people have a high rate of atrial fibrillation, when the thyroid is high. And that's always, I think, probably one of the scary things for me, when that thyroid level is running too high. And part of the way we know that, right, is that TSH level.
And then it might get some, like you're talking about, the overlapping of symptoms. Now you got your fatigue and all these type things start to happen. It looks very similar.
Yeah. So it's almost like a snowball sometimes rolling down the hill, because they'll have these symptoms, and you go, well, this is definitely hypothyroidism because they're having this, and you'll start treating it, and those symptoms may get better for a little while, but then they may come back and actually worsen, and it's like sometimes hard to know what to do. So when somebody comes in, you're getting the lab test done, and they come back, they have a normal thyroid stimulated hormone, right? That brain, they have a normal T4. What are other things that they can do and check when they're trying to figure out why they can't pull this weight off or why they're feeling fatigued?
Well, we can start to run some deeper labs, regarding the thyroid. You can run your burst T3, run your free T3 to further evaluate that to see if you're having the right amount of enzyme converting to actually help that normal TSH and normal free T4 actually get into the system and be bioavailable to work for you. So that would be the next step in going to assess that thyroid a little bit further.
Yeah. And then as well, just making sure, because there's a lot of other things as well that, whether somebody's anemic or whether they have a low B12 or low folic acid causing them to be anemic from dietary or just absorption issues, which does occur. But even then, just making sure that people get sort of a general good set of labs is important. If there's been a big change, you don't want to just accept that. It's just the most common thing to be checked, right? Yeah. Because it is an easy thing to fix. But high thyroid is a little bit harder sometimes. What are some of the things that you look at and some of the things that you do as folks roll back with a low TSH, meaning that the thyroid level is actually too high?
So at that point, we're looking at possibly using anti-thyroid medication to treat this, but we want to make sure that we get a reverse T3 to see where our bioavailability is. The second thing, if that's the case and this is hyperthyroidism, we need to use an anti-thyroid medication, but then I'm seriously thinking about sending the patient out to a specialist, to endocrinology, to get some further evaluation with that and get some help with that.
Yeah, it's always hard because there's classically sort of two paths that we will run down, right? And one is, do we just do the medication to suppress the thyroid? Or if it's really bad, do we give medication to actually kill the thyroid? Of course, that's really where you need an endocrinologist who specializes in that to help make that decision. I would say today we do far less ablation of the thyroid or killing of the thyroid than we did 20 years ago. Just in my practice, we're using these medications just to suppress it. Sometimes we have to use some blood pressure medicine as well until we can get that sort of in a good, the thyroid level in a good place. But really what happens over the course of time, a lot of people who have a high thyroid, eventually that thyroid sort of, for lack of a better term, burns out. Yeah. And then we have to make a switch from where we're trying to suppress the thyroid to actually replacing the thyroid. Yeah. And make sure that their thyroid levels stay up. So the other classic debate through the years has been, do we use generic levothyroxine, which is kind of the classic gold standard, or do we use what everybody knows it as would be like an Armour thyroid, but it's really where they take thyroid glands from pigs and they crush it up. That used to be the only way that we could get it, right? And so it has sort of a combination of T3 and T4 and probably a little T7 in there as well that gets from pigs. And so how do you end up sort of starting medication when somebody comes in with low thyroid, picking between those two options?
A lot of times I find myself treating the patient and the side effects to the medication that they have and the efficacy that I'm getting from it. Whether the efficacy is I got a better lab, but is that better lab, is the patient feeling better? Is the patient having less fatigue, these type of things? So I usually start off with a levothyroxine, but if the patient is having a certain type of side effects, I may switch to epi-thyroid, these type of things. So it's really kind of what the patient is responding to and if the labs are responding as well.
Yeah, I think that's that's always key is we're not treating lab numbers, we're treating patients. Certainly the lab numbers that help us treat the patients. And I think as well, I always start with the levothyroxine as well, just because if you look, there is the benefit. We need the different types of thyroid in our body, but when the thyroid is making it, right, all these other things are really converted in other places in the body besides the thyroid. And so if you have enough of the T4, which is what levothyroxine is around, the body can usually handle converting it in the other places. It's kind of like vitamin D, right? Vitamin D isn't just in one place. You have different sources, and then it gets converted into these active vitamin D with the kidneys. And so even though you may not have a thyroid, you can still convert these other types in the other places in the body where it's needed. And so I usually don't worry about replacing some of those, because sometimes what you do is you get a little off kilter. There's some ways that you can certainly use two different types of medication and do it, as opposed to getting something that has a sort of fixed combination in it. But quite frankly, I figure the body is the best one to decide, right? How much it needs of each one. Now, there are some people that have a deficiency in that enzyme, and they need some help, right, with that conversion, because their enzymes genetically just aren't there. But I would say that's pretty uncommon. I won't go so far as to say it's rare, but it's pretty uncommon to have that. I'd say probably 90% of people, and again, I don't have an exact number there, but I'd probably say 90% of people, 95% of people maybe even, if they're just given the T4, they have no problem converting in the rest of their body. I think as well, when you have these guys that you're feeling fatigued, you're feeling tired, could it be thyroid? Absolutely, it could be. Is it likely? Chances are, in today's society, it's not. Now, again, it's one of those things that's really easy to fix. You need to check for it, but we also need to be looking at a broader spectrum. But that's probably, I hate to say, one of the most common complaints that we get when people come in is, I feel tired. And thyroid's a great place to start.
Yes, I agree.
So, all right, let's go see some patients.
All right.
And like we say on Tuesday mornings, go dogs, seek them.